Greetings. My name is Dr. Jacob Curtis. I'm a board-certified family physician at Grand Peaks Medical in Rexburg and St. Anthony, Idaho. I've been asked today to do a video, an educational presentation, if you will, on colon cancer screening. Previous to this, one of my colleagues, Bryant Hansen, one of our fabulous physician assistants, did a presentation on cancer screenings, generally speaking, but I've been asked by our nurses and our patients to focus in on colon cancer screening and specifically instructions on how the collection process works. So with that, we'll begin. As always, we have a little disclaimer slide. Just a reminder to us all that this is not to take place or take priority of medical advice given to you by your primary care provider and or specialist. If you have questions or concerns regarding your health, you're encouraged to call your primary care provider. If you're having severe emergent symptoms, you should call 911 and seek urgent medical attention. Colon cancer, also known as colorectal cancer, even though the majority of cases are in the colon, about 80% versus 20% in the perirectal area. It's the third most common cause of cancer in the United States, affecting both men and women. Number one is skin, various skin types of cancers. Number two for women is breast. Number two for men is prostate. But number three is colon cancer. One of the reasons we're so passionate about colon cancer screening is, unbeknownst to perhaps many, it's one of the most preventable. What do we mean by that? If we catch it in its early precancer stages, we can progress the spread to becoming something that otherwise might be life-threatening. How prevalent is it? Over 100,000 new cases of colon cancer are diagnosed in the United States annually. So what's that mean in our lifetime risk? About 4.4%, which means about 1 in 23 men or 1 in 15 women. It'd be very common for each of us to think of somebody that we know, perhaps in our extended family or friendship circle, who's been affected by this disease. What are the preventable risk factors? They're listed as follows. Our BMI, as our weight goes up, that can increase our risk of colon cancer. Not being as physically active. Diets high in red and processed meats, I'm a little guilty there, but we can reduce the risk somewhat by the temperature in which we cook our meat. Specifically, charred and grilled and broiled and fried cause it to be more charred, which has more carcinogenic or cancerous properties. So cooking things low and slow. So thank goodness for my wood pellet smoker. Low vitamin D can also play a risk, and so we might see that in colder areas of the country, more northern latitudes. Smoking, alcohol use are also preventable, not that we can necessarily adjust our age. There's also some non-controllable risk factors, family history, personal history, as well as genetic predispositions. Colorectal cancer screening is recommended by the United States Preventive Services Task Force. They're kind of the gurus who make recommendations, working in combination with the different physician associations and the American Cancer Society, have long established for over 2 decades that the ideal time to start screening is at the age of 50. Before that age, there's a higher likelihood of false positives, undue stress, and biopsies. Greater than that age, we're going to miss more. Now, we all know of cases of individuals who are sadly diagnosed in their 30s and 40s and may have passed away from the disease, almost always with a genetic predisposition. Those are the outliers. That doesn't necessarily justify screening the entire population. Although if you do have a family history with a loved one, a first-degree relative who has unfortunately been diagnosed and or passed away from this disease, the general recommendation is consider starting screening 10 years younger than the earliest family member diagnosed. But for everybody else, age 50. What are the options by which we can screen for colorectal cancer? They're as follows, from probably least benign and more frequent to the more invasive. So there's annual screening with fecal occult blood testing. I'll go over these in more detail on each adjacent side. Flexible sigmoidoscopy every 3 to 5 years. What's referred to as CD colonography every 5 years, and a colonoscopy. I'm going to discuss those in more detail now. So what is fecal occult blood testing, also known as FOBT? It can also be referred to as fecal immunochemical testing. It's a less invasive test that's actually done in the privacy of your own home. You're sent home with materials, usually from your primary care physician's office. And they give you instructions, hopefully clear, on how to obtain a sample and then prepare that in such a way that it can be sent given back to the primary care office or sent to the reference laboratory. What are we doing with these tests? almost universally they're screening for occult blood. What does that mean? Blood that may be microscopic and not visible to the naked eye, such as that which we might see with less serious conditions such as hemorrhoids. But they're looking for blood just because oftentimes colorectal cancer can be associated with this microscopic occult blood. And so that's what it's screening for. The best results are when individuals do the annual screening with the fecal occult blood testing and also get at least a flexible sigmoidoscopy, which looks at about a third to half the colon every 3 to 5 years. What are the benefits of this test? It's quite sensitive. It doesn't require bowel preparation in the same manner that a lot of the more invasive diagnostic tests. It doesn't require anesthesia. It doesn't require transportation to and from the screening exam. What are the limitations? It doesn't appear to be quite as accurate as more invasive diagnostic imaging tests such as the colonoscopy. There can be false positives that can kind of cause undue stress. If you do get a positive, and it's tough to estimate the percentages, but it could be anywhere from 3 to 20% of the population, depending on risks, an invasive test is then recommended. So how's it done? The patient is sent home with a kit, obtains a stool sample, applies it to cards, and then returns the kit to the clinic, and a reagent is provided. And if positive, the patient will be notified, and a direct visualization exam is recommended. Here's a Shutterstock image that shows it. I'm not using this for commercial use, and so we're okay to do so. This steps you through, but I'll give you kind of live demo. Historically, we use these hemoccult cards in the office. We take a single stool specimen. It's collected in the basin, a swab, a gentle, small sample, provided that card. It's clipped. On the other side, it's opened and reagent is dropped. It's okay. This is what we've had for years. Probably not as sensitive and accurate as what's become more of the standard of care. We use in our office and send home patients with the HemoSure test, which is a one-step immunological fecal occult blood test. The instructions in step A, I talk to the patient about how to contain the specimen at home. Then it steps you through the processing component where you unscrew the cap on the purple tube. Very easy to do. There's a swab on there, and it recommends going to the specimen about 6 times and then putting that back in, closing it completely, shaking it, and put it in the biohazard bag, and then in the envelope that will go back to your primary care provider office or mailed in, and then wash your hands afterwards. And so that's, again, a less invasive test. In our office, we primarily use those who are uninsured or underinsured because it's more affordable too, although as hinted earlier, may not be quite as accurate and as effective as some of the other more invasive tests. So that's the first. What is a flexible sigmoidoscopy? It's an invasive scope done on average every 5 years, some perform every 10 years, in combination with the annual fecal occult blood testing. It's less beneficial alone. The availability and popularity has declined greatly in the United States. Benefits, it provides partial direct visualization, but as already implied, it's not looking at the entirety of the colon or the large intestine, another name. So those are the limitations. How's it done? A bowel prep is given the day prior, usually a drink, causes some loose stools, eating lots of Jell-O, some cramping associated with that. And depending on where it's done, historically done in a primary care provider's office, they may or may not provide an IV and or sedation. And so intuitively there could be some discomfort with that, then the procedure and recovery. This is what it looks like on a graphic. On the bottom right, you can see kind of the lumen of the inside of the colon. It's not quite what people would expect. It's actually very clean, and it shows that mucosa quite clearly. And what the doctor is looking for is a polyp that could progress to cancer. CT colonography is another option. It's performed every 5 years. Its benefits are it's less invasive. The limitations, it's unable to diagnose at the time of procedure. It's just evaluating, but additional tests would be necessary. If an abnormality is identified, would then require more invasive exam. There are potential harms with this too, specifically the harm of incidental findings. Sometimes we'll call these incidentalomas. In other words, it's not just looking at the colon, it's looking at adjacent structures. We might see something that's completely benign, non-clinically relevant, but could cause a lot of worry, stress, and anxiety for the patient and the provider, and result in additional, sometimes less necessary biopsies and procedures and stress trying to identify that. And there's also some radiation risk. How is it done? An oral contrast is administered. A CAT scan of the abdomen and pelvis is performed, and the findings are interpreted by a radiologist. This top graphic on the left shows a CT scan going through, and the bottom images show the radiographic images in A, B, and C of what that looks like on the CT, and D and E show kind of real time what those images correlate with. And so that's a less invasive option. And lastly, and this really has become what we might refer to as the gold standard, a colonoscopy, performed every 10 years, beginning at the age of 50. This is again for screening purposes. The benefits: it requires less frequent screening every 10 years and diagnostic follow-up of positive tests. Can also be done. What that means is if they see an abnormal polyp, you don't have to schedule an additional procedure. It can be sampled at that time. Limitations: there is a bowel prep, an IV is started, sedation is provided, so the patient is not awake and conscious and alert. They don't have to be intubated, but an IV sedative is provided. There is about a 1% complication risk, especially if biopsies are obtained. There's a risk of infection, bleeding. Wish that number is lower, but still pretty low for the benefits it conveys for a cancer that is the third most common cause of cancer of American men and women. How's it done? Much like the flexible sigmoidoscopy, a bowel prep is done the day prior, IV sedation, the procedure and recovery. And this is a visual demonstration of what that might look like and covers the entirety of the colon. And so, in conclusion, nobody, I think, wants to get this done. It doesn't sound super pleasant, but part of being an adult is making adult responsibilities. We wear a seatbelt, we have to do other safety things in life, and this really can be a gift to your posterity. I sometimes joke with my patients, wrap up your results and give it to your kids as a Christmas gift. And so specifically, it's recommended at age 50. Trying to put it off. Again, the discomfort is really worth the peace of mind. It breaks my heart when I see individuals who haven't had this, who are diagnosed with metastatic colon cancer that becomes life-threatening and takes them away from their loved ones and families at far too early of an age. So please consider having that done. Please feel free to talk to your primary care provider. If you don't have one, my staff and I would be happy to reach out. Thank you for your time.